We have an unprecedented discussion. What we have here is an information sharing session. This is arisen out of a huge interest, particularly from the media and civil society and for the public in general, to find out how we are looking at the unfolding pandemic, the COVID-19 pandemic, and therefore the questions have been asked to share a bit more on the information. In the course of all of this, we must appreciate that this has been an unfolding epidemic that over the past few months, we all have been trying to learn what it means, what are the implications for South Africa. We also understand that the whole world is struggling with exactly the same pandemic, and that no one in the world has got full answers, but that there are lots of lessons that we can learn from and actually use those to guide our response as South Africans. It's also become very important to say that there may well be situations where we learn, we have lessons which we can share with the world simply because of the uniqueness of our own situation. So we've also understood that there is no immediate right or wrong here. It's a matter of doing your best. And at the end of the day, we'll have the correct scientific analysis and research that every now and again gives us a guide in terms of what the experiences are in different parts of the world. So as the Department of Health, we have learned from various countries to look at what is the best way to respond to the outbreak. We have also been sharing with various scientists and researchers and authors to look at what kind of experiences are on record to be able to help us through. Some of the information that we got from some of the researchers has been helpful. Some of it we have just observed and probably never utilized. In some instances, we have debated and argued. In some cases, agreed and disagreed. So you really are having this discussion is almost getting, it's almost like getting into a workshop where the car is being fixed, but we can only know how well, which one works best when the car is being tested on the road. So we do anticipate that there will be things that would have gotten right, there will be things that would have gotten wrong, and so we'll only know once we've got to the other side of the whole pandemic. But where we are, we've done our best in trying to respond, and I must say that so far we've had the utmost cooperation from literally everybody, and I want to say particularly that the most important weapon that I believe we really need to focus on is correct information and sharing the information in such a way that it allows our people to have more insight into the unfolding pandemic, and therefore help them as individuals and as citizens to respond appropriately, because the key issue is that we will defeat the pandemic on the basis of collective behavioral, social behavioral change that creates a whole new culture of distancing, of use of masks, of use of cough etiquette, and ensuring that everybody is conscious of their individual roles as the ones who must actually make sure that we limit the spread of the infection, either not passing it on to the next person or avoiding it getting onto yourselves. So this basically becomes a people's war against COVID-19. It becomes a people's fight, because unless our citizens themselves take responsibility of the infection or control, then of course we will not be able to win. What Dr. Tedros, the WHO Director General, was saying, that we are as strong as the weakest amongst us. The weakest are those who will either succumb to the infection, or those who will not have the right information, those who will be overwhelmed as individuals, and therefore, of course, that becomes an entry point for the infection. Now, we've seen the way the infection has unfolded in the country. When we started with the first case reported on the 5th of March, we suddenly noticed that for the first few days, we had a doubling time of 2 days, and this was driven by the imported cases. And as a result, when we looked at it and comparing with the rest of the world, it looked like our trajectory was going to be similar to the one of the United Kingdom, with a very rapid rise on a day-to-day, patient-to-patient, case-to-case kind of count. It became clear that our numbers were going to rise pretty rapidly. And although it was also unprecedented, not many countries had done it, but we ended up having to take a decision to embark on a lockdown. And this lockdown is really the most extreme form of restriction of movement, and our message was stay at home. Now, that message had already been the same message that we had seen in Wuhan, in China, in Italy, in different parts of Europe. And that message, for most of the countries, came somewhere in the middle of the pandemic. But in our case, we took that decision early. But when we did the analysis afterwards, we got a good sense that there was epidemiological shift of the curve, which means that the first curve, which could have really been an immediate explosion, was deferred for a while, and this was shown by the graph, our graph showing a trend that was changing the trajectory and really showing a bit of flattening at that point. We all were aware that despite all that, the internal transmission, once it sets in, is going to have its own dynamics of raising the numbers of positive cases again into the country. And our major concern was that it would go into areas where there are more vulnerable individuals with comorbidities, with overcrowding, where isolation and quarantine are difficult. And therefore, this was going to be the major part of our problem, which was going to give us a huge a surge in numbers. And so we needed a bit of time to try and increase our health services. And in this case, this is when a lot of modelers started coming in to look at what the figures were likely to be, and that at the end of the day, what are we likely to end up with in terms of the potential of surges that can be looked at. So we've seen a number of different models that have come on board. All of them are basically independent models. And these models, some of them we've engaged with them. We agree with them at certain levels. We disagree with them at certain levels. All of them, where we think that they've got useful information, sometimes we'd utilize that. Where we think we're not happy with the information, we simply don't utilize it. But what it has really generated is a very rich exchange of various forms of computations, calculations, modeling, forecasts, which basically are about trying to predict where we will land as a country. And therefore, with this symposium we don't anticipate that any one of the models will necessarily be said, well, this one is the one that got 100% right. We just know that what it will do, it will open up to a conversation that allows us to improve our sense of prediction as we move on. We're aware that many of the models are looking at different aspects of the pandemic, and many models are using different assumptions and different considerations. So they may not necessarily be all the same, but there would be something that you can learn from the one model and from another model. And some of them focus on areas where we may not have answers for. And so I would say, therefore, that the fact that we have opened this up today is a learning experience for everybody. We also want to hear a bit more from the Department of Health. We also want to hear a bit more even from those who are watching from outside, what they think. And that at the end of the day is going to help to improve the model. what we have at least agreed with the models is that where they started with postulations which were based on various considerations that were based on various countries' experiences, but we didn't have enough information about what is happening in South Africa. That over the past 2 months or so, we've begun to have more information for purposes of refining the models and going forward. But I think as we do so and as we say so, there are certain things that would be clear trends of what's happening with the pandemic in the country, but there are also lots of areas of internal dynamics within which you might find that it still doesn't mean exactly the same thing. So, for example, if you're looking at the distribution of the infection in the whole country, it's not uniform. So there are areas which have got very low, case positivity rate. There are others which have got very high positivity rate. What drives the two, what makes the difference, is something that is subject of continuous research. But if you look at the numbers, are you going to use the numbers from one province or the other? Are you going to aggregate all of them and try and work on them on that basis? Those are the issues that the modelers have got to take those issues into account. They may agree, they may disagree about them, as it were. But where we stand as the department is that those models are going to go on there. This morning, we were actually met up with another group of models that were asked to join as well. We've tried to reach out to as many as possible.
All right, well, let's take you now straight to that Zoom symposium where modelers have been working hard to predict the pattern and spread of COVID-19 there in South Africa. They are presenting their strategies.
Have raised various issues. And so there's an angle where there's debate that will go on. There are areas where we are having to implement certain things. We'll implement certain things where there's either known, there's clear knowledge about them. There may also be areas where there's disagreement, and therefore we have to make a call that on this basis we'll take this route. If we're correct, we'll move on. If we think later on we are not right, we'll change that. And this is really what it's all about. So at this point, I'd like to just introduce the members of the panels who are with us here today. There is a group of panelists that we did invite yesterday or 2 days ago to present to some of the editors. That's the consortium that we have worked with for a while. It's not almost like we have taken all what they've had to say, but we worked with them and tried to understand what is involved. But there were many other models that we may not have actually contacted. So, and they are modeling for various reasons, and some of them, they're really for their own business guidance so that they know what they're doing. So all of that means that there's a huge conversation going on in South Africa. We will not answer the questions this time around. We will just intervene where we wish to intervene, but largely the media is invited to ask questions to the panelists. And I think for a while it's nice not to be the ones to answer the questions. And so all the modelers, those who have had things to say in the media, they've got now the opportunity to say those things to the other modelers, and let's hear the debate. And then on the other side, there are those who have raised questions to us, and those questions must be answered by other models here, because most of the issues that relate to modeling is not original within the department. So the approach here is that we're going to take various presentations. The first group of presentations, as far as our program is concerned, will come from Ashley Theopatides from Deloitte. They're working with Business for South Africa. And then there's another one that comes from Perry Childs from Actuarial Society. Then there's another group, which is the COVID-19 Modeling Consortium. That's the one that was working with the department. That's got NICD, NHLS, Marsha, Sasima, Hero, and Wits University, Cape Town, and Stellenbosch University. They'll present their own. There are other modelers whom we have picked up in the media, and that we have seen that are part of the discourse. I see that there's an intervention model for planning. and pharmaceutical interventions for planning, pandemic data, multidisciplinary initiatives seeking to inform policy, and then other spatial models, financial implications models for implications for lockdown and recovery, movement of cases, and so on. So that whole agenda is in front of you. It's going to be fleshed up there. Then as soon as I've finished my comments, I'm going to invite the Director General, Acting Director General for the Department of Health, Dr. Anban Pillay, to facilitate the process of the exchange. So the presentations will all go up to the end. I invite you to make notes so that you will then ask the questions at the end. Really would like you to focus on asking the modelers the questions. And the department will comment when we wish to comment, but we would want you to focus on the models that have been put on the table. This is about trying to share more information about it. So at this point, therefore, I'd like to invite you all to relax and enjoy the presentations. And Dr. Anban Pillay is going to, from now on, facilitate the presentations. Thank you very much for attending. Dr. Anban Pillay, please take us through the process. Thank you very much. You're all welcome.
Thank you, Minister, and thank you to colleagues for the...
Sorry, Anban, your volume is a bit low. I think you should get closer to your gadgets so that you can hear you. Thank you.
Can you hear me now? Is that much better? No?
All right, proceed.
Hi.
Proceed.
Hi. Thank you, Minister, for facilitating the first part of and your opening remarks. So we'll go straight into the presentations. As Minister indicated, the first group of presentations are largely linked to projection models. And the first person to do the presentation will be Ashley Theophanides, who's going to do the presentation on the Business for South Africa model. I'll ask Barry Charles to be ready thereafter with the Actuarial Society model. And then finally, Dr. Sheetal Sula will do the Masha model. So if I can ask Ashley to please put her slides up. I assume she has slides, and start her presentation. Over to you, Ashley.
Thank you, Barry. Can you see my slides?
Yes, slides are visible. Please proceed.
Thank you very much. Thank you so much for giving us the opportunity to present today. The presentation that I'm going to be taking you through is very much focused on the work that we've done with and for Business for South Africa, collaborating with various people within Business for South Africa, but also with the Department of Health, National Treasury, and a number of other departments. This work is very much focused on trying to identify the level of PPE, ventilators, hospitalizations, etc., that may be needed in order to support some of the demand-based requirements that we will need over time. In my presentation today, I will be focusing on the results as they currently stand. I will then also give some highlights of the updated modeling that we're currently doing. The models are currently being recalibrated. We do this every few weeks, but I have some preliminary results available. I think what's very important to note is that a model is only as good as the inputs that go into that, as well as having a sense as to what the various behavioral elements as well as calibration factors that influence the results itself. In the modeling that we have done, we've very much focused on trying to incorporate not just epidemiological infection rates, but also allow for changes such as weather. So the fact that we are going into winter, we believe will have an impact on the reproductive rate by that being increased. We also believe that various social policies, various levels of social distancing, as well as significant initiatives around testing, tracking and tracing, and the effectiveness thereof are incredibly important in order to manage, first of all, how the disease spreads, but then also the severity thereof. So as we look at the assumptions, you could see at a very high level, we've allowed for the various factors that have been incorporated. So we can see the factors of winter coming in, we can see aggressive testing, as well as warmer weather coming in towards the third quarter of the year, allowing for a reduction in the reproductive rate. And that's quite important because as we allow for these different behavioral elements, as well as people abiding by various forms of social distancing, we believe that this is our best estimate in terms of the results. However, depending on how this spreads, as well as the way that the virus spreads between more community-based infections versus more isolated cases is incredibly important, and that's why the calibration is very, very keen, as well as how that changes over time. On the bottom right, you can see the total cases and how that's been calibrated to the model itself based on the available information we have to this point. I think another very important aspect to consider is hospitalization. We have allowed, I mean, this is a very crude illustration of what we've allowed for in our models, but as we know, the virus very much influences you based on age, comorbidity status, and any other underlying ailment that you may have. This is, of course, incredibly important when considering hospitalization, both from international research as well as research that's been done based on our own cases. We see that older people and people with comorbidities do require more hospitalization or a higher level thereof, as well as we see that that influences the case fatality rate. So as this moves through the population, it is important to continue to calibrate it, allowing for the very specific dynamics of the South African population. Being a younger population does to some extent support us in keeping hospitalizations quite low. Or lower than what it would be in populations that have a higher proportion of elder individuals. What's also important based on research as to how this is unfolded in other countries is the availability of hospitalization beds. So the work that the department has done in order to set up and facilitate field hospitals is incredibly important, because lack of hospitalization also has a significant impact on the increase in the fatality rate, which is why it's important to manage that and ensure that there is appropriate facilities for those that need it. So if we move to the results, in the graph on the slide here, you can see the expected number of hospitalizations, and this was based on the model that was calibrated on the 20th of April. At the end of the presentation, I will be taking you through some of the updated results, but those are still being finalized. You can see that the green line shows the total total admissions, as well as then looking at PUI admissions. PUI admissions being incorporated is quite important, given that it is quite key to try and assess the part of the admissions that relate to people who haven't quite been determined as being COVID positive, but are being watched. And this data is being further refined by the various hospitals. We then also need to look at this in order to establish the level of ventilator requirements, and these are specifically APAP, so your invasive mechanical ventilators. And on this basis, it has been calibrated, allowing for the level of admissions based on actual experience. So this is based on 15% of those that are in ICU and high care. It is then, of course, important to also look at oxygen. We know that the treatment protocols are changing, and as it stands now, 23% of admissions have been requiring oxygen. So monitoring that over time is also very important. What's also key to see is that the adjustment for PUI is higher in your general ward compared to ICU, which one would also expect. If we look at some of the results, so these show the maximums coming through at various points in time. So we know April and May has passed, but this is when we did the results. So if we maybe focus on May, we can see that the maximum number of ICU beds needed based on the projection at this point was just under 500, ICU at 744, the ventilators at 146. We also then see the total number of hospitalizations, which was the 2,638. So that also allows for our general ward admissions. And then, of course, the expected number of deaths. At the end of May, it was expected to reach 419. And as we know, we're currently standing at 339. And then, of course, the proportion of patients needing oxygen. As we know, as the healthcare protocols change, this will, of course, also then need to be updated in terms of the demand for these services. We then project this going forward and all the way up until August, which is where these projections ended, showing roughly 7,000 beds needed in August for ICU. If we look at the range in terms of ventilators and oxygen requirements, the top line is oxygen requirements over time, and then ventilators, just showing the peaks occurring in August. Then if we look at PPE, so the PPE is based on the demand factors as per the table, showing, for example, number of N95 masks. And the way in which one would interpret this is that there is, based on this, 25 N95 masks needed per person per bed per day. This is, of course, using the occupancy in the bed as a driver in order to determine the number of masks needed, all the way through to gowns and gloves. This is currently also being updated, allowing for the actual experience that we're seeing. When we model this out, we can then look at the level of PPE needed over time so that we can then determine the availability of stock and how this can be used. This is just showing it all together. As an example, we can see based on these projections, we're looking at needing roughly 16 million N95 masks in July. So these are the results that are currently being updated and calibrated based on the most recent information, but just to give you a sense of what we're looking at. So we can see that based on this, the expected number of COVID cases are expected to peak around August, September. We can see that the results showing approximately 3 million people. I think what's quite important to note is that the various interventions that get applied will, of course, influence these results. And as people abide by various social distancing processes, we can, of course, keep the cases as low as possible. Then if we look at the results that I showed you earlier, we can see the number of hospitalizations coming through, both the total hospitalizations as well as the patients under investigation. And then, of course, we can use this in order to project the level of ventilators, oxygen requirements over time, as well as hospitalization. This can then be populated down into a province level in order to support the provinces in ensuring that there is appropriate level of beds available. What's, of course, important is, as I mentioned earlier, people needing needing hospitalization, specifically in ICU, and not being able to get access to these facilities would, of course, have an impact on the case fatality rate. So that is something that we need to keep an eye on to ensure that progresses over time. And as the clinical protocols change, this, of course, also influences a number of other aspects, such as the demand for medicine, etc. And as these protocols change, specifically from a ventilator perspective, the level of sedation, especially for APAPs, is quite important to understand, because that will, of course, drive the medication required and the availability thereof. So if we then allow for this in terms of looking at PPE again, we can see the demand for PPE being coming through here. Again, looking at significant numbers of N95 masks based on our initial updated results as at June, looking at just over 20 million N95 masks as an example being required. What is important to note in the modeling, there are two aspects. So the one is, of course, the EPI models, which is incredibly important, but then also the calibration of the EPI models and the outputs of those EPI models to the demand drivers. So as an example, if instead of needing 25 N95 masks per occupied bed per day, if that number only needs to be 10 or needs to be 35, that will, of course, drive the results. So as information becomes more available and the use of the various PPE, as well as the specifications in terms of the types of masks, the types of gowns, etc., gets further refined, we can then, of course, ensure that this is refined and appropriate levels are determined. And then finally, looking at the projected number of deaths, based on the current set of assumptions, our best estimate at this level is sitting over 40,000 deaths coming towards the end of the year. Given the comments that I've made earlier, this level would, of course, need to be reconsidered given availability of facilities, as well as looking how the community-based infections occur and how best we manage that. But these are our best estimates as they currently stand. Thank you very much.
Thank you, Ashley. Thank you for the presentation. Can we, in the interest of time, move straight into the next presentation, which is doing the presentation on behalf of ASPA.
Hi, everyone. Can you see the slides and hear me okay?
Yes, we can see them, Barry. We can see them, Barry.
Thank you. Let's move swiftly along. I'm mindful we're a little bit behind time. Thank you very much for the opportunity to present. I'm hopefully going to add some context and some other perspectives to the discussion around modeling, particularly talking a little bit about what we don't know. Our process started on the 16th of March, where it became clear that we needed to do some work. We called together some volunteers, worked frantically to produce some modeling code, literature reviews, etc., and published our first set of results on the 28th of April to the broader profession. Since then, we've received significant critique. I've presented our results to close on 1,000 of the actuarial community by now in various forums. I can tell you they don't hold back their criticism and input, so we have a flood of input from them, which we're hoping to incorporate in model refinements as we go. Our approach is to produce a model for the broader profession to use. Actuaries, of course, are interested in things related to mortality and morbidity, and we hope to use this work to contribute to the national debate Special thanks to the contributors there. I've given a list on the slides, but particularly to actuaries from Percept and NMG who did some of the heavy lifting. We have followed here a compartmental model similar to some of the other modelers, a modified SEIR approach. You would have all seen that with the NICD Modeling Consortium's presentation, so I'll try not to spend too much time talking to that detail. Safe to say that the model allows for transitions into different states, and then eventually you exit through the model either recovered or dead. I won't go through exhaustively the assumptions. If you all are interested, the model is fairly well documented, and I can send you links to those documents if you would like to interrogate that further or engage in questions. The important thing is to understand the sensitivity to certain assumptions in these models, and I'll talk a little bit about that. So when we produced our first set of scenarios, the intention was to say, what are the sensitivities to various of the parameters in these models? So scenario one, a base scenario, if you like. Here I'm just showing the projected outputs for overall hospitalizations. The colored lines, the purple, red, and green lines show scenarios 1, 3, and 4, which use different assumptions for the effect of the non-pharmaceutical interventions on the dampening of the reproduction rate. So it shows that basically you buy time. It spreads out the rate of infection. It doesn't make a huge difference to the overall mortality rates, other than the potential overflow from shortages in hospital facilities. Scenario 2, we showed to make the point that these kinds of models are very sensitive to assumptions. So if, for example, you change your assumption for the asymptomatic proportion of the population, then that's going to have a big effect on the deaths. One of the things we've been criticized for is not producing a wide enough range of scenarios given the sensitivity to the key assumptions. And so in upcoming updates and releases, we hope that we'll be able to show some more data there. The kind of critique, and I'd maybe like to use this opportunity in this audience to talk about the kind of critique to the models that we're getting. So, because perhaps more than the other modelers since we released earlier, we've gotten as I say, an extraordinary wide range of critique. I must say, some actuaries are saying we're way too high. Some are saying as much as 4 times too high on deaths. Some actuaries are saying we're way too low. Some are saying as much as 4 times too low on deaths. And those critiques take various different forms. Some of them relate to model structure, shortcomings in the model structure. As we've really gone into the detail of how these models work, it's become clear what some of the shortcomings are. For instance, not allowing for spatial dynamics or heterogeneity in the population, variations in infectivity and susceptibility. All of these things, ideally, you need to allow for. So the high-level compartmental models are quite simplistic in that they don't allow for certain population dynamics, and we know this, and we need to take this into account in further refinements. But the models are driven by parameters. Some of the critique is about the parameters, infection fatality rates, and other parameters along the course of the curve. But then the other kind of critique comes from looking at the data. So if you look at a projection, we're projecting around in the mid-40,000 deaths by the end, and that assumes a scenario where the virus does run. We'll manage to spread it out and slow it down with the non-pharmaceutical interventions, but we haven't managed to really crush the curve, to use a different language, like some other countries have done. For whatever reason, it may be some other countries have walked a very low road. I'm showing here the sort of top 12 or 13 countries in terms of overall fatality rates as they're emerging at the moment. Many countries have walked a much lower path, and we don't really know why that is. It could be much lower susceptibility for some reason, or various other factors. Other countries like Australia, New Zealand, South Korea, the way that they intervened, shutting their borders, aggressive surveillance-based test and track and trace, managed to shut things down much earlier than other countries that were more severely affected. But the kind of critique you get is, look at Belgium, look at Spain, look at Italy. Their, deaths per million are 600-700. although we know that the pandemic isn't over there yet, they have turned the corner, at least for this first wave, and the death rates are starting to plateau. So why would we expect South Africa to be so severely affected because of our younger age population, etc.? So these are some of the kind of criticisms that we get in the models, which we're trying to assimilate, and think about, and factor into our refinements going forward. Some of the concerns, just looking at the data, are things like underreported deaths in some countries. There are reports that say in the UK deaths are underreported by 50%. Looking at excess deaths, the potential re-emergence of cases when the non-pharmaceutical interventions like lockdown are lifted. So lots of concerns, lots of uncertainty, and that's really the message that the take-home message, I guess, I want to give you. That the difficulty here is making such significant decisions amidst such uncertainty. I also wanted to give some context because I think that's missing in some of the discussion. So when we look at mortality overall for the country, you've got to compare that against something. We have, it's useful to have these rules of thumb in your head when you're thinking about deaths of, whether it's 20,000 or 40,000 or more. We have 480, 500,000 deaths a year in South Africa. And I think it's important for people to understand, what the makeup of those is. We have about the same mortality rate as some of those European countries on a deaths per thousand basis, which is quite high relative to our age profile. And the reason for that is we have this high burden of disease with HIV and TB particularly. HIV deaths are still around 70,000 a year, HIV and AIDS-related deaths. They're off of their highs in the sort of from 10 years ago. TB deaths around 30,000, flu's sitting at around 10,000, NCDs around 100,000. So these are all, in a sense, preventable deaths. And I think it's important to, when we're thinking about around the estimates for COVID deaths and the way we think about it, important to bear those numbers in context. And then lastly, given...
Sorry, Barry, can you try and wrap up in the next 3 minutes?
Yeah, absolutely. Thanks, Anban. And then lastly, or almost lastly, we have some significant concerns that because of the focus on COVID, that there may be compromises on other areas like HIV. I mean, people not getting their medication would be a real problem because we know that ARV compliance is significant. So this is just to flag a concern that we mustn't take our eye off the ball on the treatment of other conditions while we're sorting out and trying to suppress this pandemic as much as we can, because there's a sort of leverage effect, and we may be stuck with other problems down the line if we drop other balls because of the focus. I was going to present one more slide, so I'll start with that, but Anban, you can cut me off at any time when you want to move on. If we think about the factors driving our success and how we're doing, age profile is pretty good by international standards. Our comorbidities are moderate compared to international standards. HIV and TB are a real problem, particularly HIV, and so that may present a risk, although not for people on treatment, but potentially for people not on treatment. Obesity, we have moderate to high levels of obesity. We know that's a key risk factor. Density explains why, population density explains why the hotspots are where they are. And in terms of what we've actually been able to do, early lockdowns bought time. Testing has been good by international standards, but delays remain a key problem. Overall, bed capacity looks manageable, but ICU capacity may still be breached. And then generally, from a policy point of view, education and awareness has been great, but difficulties in compliance persist, which we're concerned about from a policy point of view going forward. And that's it.
Thank you, Barry. Thanks for trying to keep to time. We can then move to the next presentation, which is the consortium model from a group of researchers from various institutions. I think Professor Juliet Palliam is going to be doing this presentation. So, Juliet, if you can put up the slides. Thanks. Please go ahead, Juliet. You may need to unmute.
Morning, thank you. It's my pleasure to present on behalf of the South African COVID-19 Modeling Consortium this morning. I am also presenting on behalf of my colleagues, Dr. Sheetal Sealal, who's the director of MASHA, the Modeling and Simulation Hub Africa, Gassina Meyer-Rath, who is at HERO, the Health Economics and Epidemiology Research Office at the University of Witwatersrand, and her colleagues as well, and then Zaid Kemi and Harry Moultrie, who are based at NICD. So the South African COVID-19 Modeling Consortium is a group of academic, nonprofit, and government organizations, individuals from those organizations who come together to discuss modeling possibilities and to validate and refine models, not just the models that I'll be presenting, but groups models as well, including a number of models that are being presented here today. The models that I'm presenting have been developed by MASHA, SASIMA, and HERO in conjunction with the NICD and have undergone extensive and ongoing input from clinicians, virologists, intensivists, and epidemiologists to refine the key model assumptions and parameters. Our projections are updated regularly. As the presenters before me have emphasized, we often recalibrate the models. That means that we take into account the new data as it's coming in. But we also take into account updates from the global literature on what's known about the basic epidemiology of the disease. So not just fitting to the new data from South Africa, but also considering how global knowledge of the epidemic is evolving. So the models that we have developed include the National COVID-19 EPI model, which is a generalized SEIR model. It includes states representing different disease severity, such as asymptomatic, mild, severe, and critical, as well as the treatment pathway, including outpatient visits, hospitalizations where patients are not in the ICU, and then ICU patients as well. We also have a national COVID-19 cost model, which is essentially built around the outputs from the EPI model. And it includes inputs from a range of sources to represent the type, number, and price of ingredients to cost the response. So these models together are used to inform research requirements and predict where gaps may arise based on available resources. Before I present the projections themselves, I'd like to say a little bit about some of the context for the projections. I think it's important to note the limitations, and there are many. These are not all of the limitations, but these are some of the ones that we're most concerned about and that we're working to address. So for one thing, the projections at a population level do not capture the clustering of cases. So there have been specific events such as funerals and church gatherings that have occurred where there have been a number of cases resulting from essentially a chance event of a large number of people being infected at one time, what's known as a super spreading event. And the type of model that we're using cannot capture that type of heterogeneity. We do need additional spatial resolution in order to do that. And a spatial model with additional granularity is forthcoming. There, I think, will be 2 different presentations later on today that are examples of that type of model. Our models project the total need for hospital beds and ICU beds. We account for stricter criteria to entry or the existing capacity. So what that means is that we are currently assuming that there will be enough beds for all of the patients that need it. And what I mean by that is that we're not taking into account any additional mortality that would occur if there is a lack of beds. Next, population behavior in response to mortality. So as the minister said at the beginning, collective social behavior change is really what we need in order to get out of this epidemic. And we know from situations such as Ebola and also from COVID and some other settings that people adapt their behavior, and particularly in response to seeing a lot of mortality as a result of an event, they will adapt their behavior and become more cautious. We do not incorporate that sort of behavior change into the model, and that's one of the main reasons that our models may be over predicting deaths, but there are other reasons that mean that we may be under predicting deaths. As has been mentioned in the other presentations, the project will improve with new data. Some of the data that we're particularly interested in have to do with hospitalization and length of stay local to the South African context. And we have a great deal of uncertainty regarding both the true scale and spatial distribution of cases as a result of changing person under investigation criteria and testing coverage. So we've been looking at two scenarios. In both of them, we assume that level 4 continues until the 31st of May and then is followed by social distancing and other MPI measures. We've been looking at an optimistic scenario, which looks at lockdown with a reduced transmissibility of 60%, or transmissibility reduced by 60%, followed by level 4 for the month of May with transmissibility reduced by 35%, and then MPI and social distancing measures after that, reducing transmissibility. Has a similar structure, but differs in terms of the reductions in transmissibility with smaller reductions in transmissibility at different points in time. So we have been generating both short-term and long-term projections. These are projections that were made from you can see that we are projecting the numbering of about 20,000 and 100,000 cases. We expect that the non-ICU beds in use will be between 1,000 and 4,000 beds. ICU beds between about 250 to about 800 or 900 beds. And that the cumulative deaths will be around 450, but somewhere between 300 and 750. So these numbers, I'm going to be showing you a lot of plots that are laid out this way. It's important to note that these are the symptomatic cases, the beds currently in use, and then the cumulative deaths, but these are not the number of cases that we expect to be detected. So by the end of May, we expect that about 30,000 of the 50,000 or so cases that are, sorry, this is cumulative detective cases, so about 30,000 cases overall will have been detected by the end of May. And you can't get that directly from looking at any of these other graphs. It's also important to note that the ICU bed threshold is around 3,300 beds. That's an estimate, but that our projections certainly do not expect that we will be exceeding that threshold by the end of the month. We've also been making long-term projections, and one very important thing to note is that the longer out into the future that you project, the more uncertain the projections become, and we're very aware of that. And but people need to be able to see what might happen in order to make decisions. So we have used the long-term projections.
Wrap up in the next 3 minutes, please.
I'll do my best. So we've used the long-term projections to investigate the impact of the lockdown and have concluded that the lockdown has flattened the curve and pushed the peak further. Pushed the peak later. You can see here that in the absence of interventions, we would have expected a peak around the end of this month. And the 5-week lockdown is expected to have, under the optimistic scenario, pushed the peak back into late August. Moving on for the sake of time, these are our national projections. So we're showing the optimistic scenario in blue and the pessimistic scenario in red. And what you can see is that under both scenarios, we are expecting to breach the ICU bed threshold somewhere between the early June and mid to late July. So that is one thing that we are particularly concerned about. And it's also important to note that although on the general beds plot, it looks as though we may not breach that threshold, many of the people who would need an ICU bed and not receive one would also be in hospital. So it's quite likely that that threshold would also be breached. Our model is predicting under the different scenarios somewhere between approximately 35,000 and 50,000 deaths, which is in a similar range to the presentations we've seen previously. But as I've said before, there are reasons that those numbers could either increase or decrease. The provincial projections show that there's a lot of variation in terms of the timing and the size of the peaks. I'm not going to go into much detail about the provincial projections other than to say that currently the Eastern Cape is looking like the pessimistic scenario that we have, so looking more like the red scenario. The Free State is looking better than optimistic. Most of the provinces are on a trajectory that's similar to the optimistic trajectory, but the Western Cape is on what looks like the pessimistic trajectory. And in particular, the pessimistic trajectory for the Western Cape is predicting that ICU beds may actually be breached, the threshold may be breached as early as the beginning of June. So our model outputs have been used by a wide variety of stakeholders for a wide variety of purposes within the Department of Health. I won't go through them for the sake of time. I'd just like to wrap up by emphasizing that the initial social distancing and lockdown measures have worked by flattening the curve. The peak has been delayed and has been lowered, although not sufficiently to prevent the breaching of ICU beds. The peak in active cases is likely between early July in the pessimistic scenario and mid-August in the optimistic scenario. But this will be affected by measures in place after the 31st of May, which are currently uncertain. There's considerable variation in timing and scale of peaks between the provinces, and the variation will be greater at lower spatial scales, such as districts and subdistricts. Approximately 12 to 13 million symptomatic cases are projected by the beginning of November, with between 475 and 680,000 requiring hospitalization. And we do expect that hospital and ICU capacity will be exceeded, though the timing and extent of exactly when that will occur is uncertain. And I'll wrap up there, and thank you for listening.
Thank you. Thank you, Juliet. Thank you for trying to keep to time. So those three presentations cover the models as projection models. If we can now go to this next set of presentations, which are intervention models. I think Alex van der Heever is next. Alex, if you could put up your slides, please.
Hi, can that be, is that visible?
Yes, we can see it, thanks.
So the purpose, so what I've put together is what I would call more a spreadsheet analysis than a full model, but it's a sort of a concept that I think is quite important in an epidemic such as this, which is actually to try and evaluate the intervention scenarios that we should consider going forward. So it follows a sort of basic SEIR approaches that we've seen. It's very much a top-down model in that a large part of the parameters themselves essentially drive the reproduction rate of the disease, which is, it assumes that certain interventions impact on the so-called R, which I think everybody's getting familiar with, which is how many people are infected by a single infected person. So the assumption, the baseline assumption in this model is that 2.5 people are infected by a single person over 4 days. That is a fairly crude assumption because it averages out quite a lot of types of people and types of infection. It attempts to match interventions to disease trajectory. And it does this, and I'll point out, through looking at the intervention trajectories of other countries and to attempt to create an assumed reproduction rate associated with an intervention. So the purpose of the model is to examine optimal strategic intervention scenarios. It's not used for forecasting. And although I can forecast, I do not trust the forecast. So it's really a model looking at the lower levels of the epidemic as opposed to losing control of the epidemic or massive escalations. So the focus is really on informing strategic decisions. The approach can be adjusted as more data becomes available. And it would be more appropriate to apply the model at a sub-regional level, although it's being designed at a national level at the moment. And there are lots of problems with assuming a sort of a single national epidemic. We're actually facing multiple epidemics at a sub-regional level. We need to also distinguish, which is not in the model, between communities, which is where people live and their social dynamics, and the bridges between communities, where different communities mix, such as workplaces, shopping areas, churches, bulk transport. That is not in this model, and therefore that complexity is not evaluated, which it should be. In all the scenarios, the model estimates the impact on health services, although that's not the primary emphasis of the model. The main focus of certainly the initial analysis was to look at prevention scenarios and what we might have to do, what mix of interventions we could consider and their effectiveness to actually impact on suppressing the epidemic, as opposed to it being it essentially reaching the levels that we've seen in other countries. The model produces estimates till 31 December 2020, and it's the interventions are applied on a daily basis. So the calibration of the model has used intervention success in other countries and assumes we should get similar results in South Africa, which we haven't. So that's going to be a complication going forward, which is looking at essentially why and what mix of interventions actually generates a suppression of the epidemic. So if we had to look at how the parameters, a sort of simple reflection of it is that if we had to look at what is the associated reproduction rate that we could get out of a generalized lockdown, if we looked at Italy, my sort of estimates assume that we get just to be clear, that a lockdown isn't the only intervention implemented at any point in time. There are multiple interventions. But if the primary intervention is a lockdown, assuming all the other interventions are in place, you might get a reproduction rate of below 1, which is what you'd expect from a lockdown. So in this case, Italy, I was estimating about 0.96. At the moment, the UK is saying that they're getting between 0.7 and 0.9. So it's broadly similar. And if you had to look at Spain and France, the trajectories are also relatively similar. But noting that this lockdown is at a much more mature phase of the epidemic than South Africa introduced, it would have been hopeful that we would have actually had a better reproduction rate. This is South Korea, where the intervention was mass testing and tracing, introduced at a very early stage. So in fact, at a stage roughly not totally inconsistent with when we introduced the lockdown. So the reproduction rate that generates their initial upsurge is about 1.6 on my estimates, and the intervention produces an R of about 0.7, which is quite efficient. So if we had assumed those parameters as intervention parameters, which is a bit crude, but it was done in April, I could use those to say, what mix of strategies could we actually do in South Africa to maximally and most efficiently suppress the epidemic over the 2020 period. So the way the model works is you look at individual interventions with associated reductions in R. You use those to build response packages, which involve combinations of interventions that produce an aggregate R, which is basically the top-down modeling assumption that gets made. And then out of the response packages to generate 2020 scenarios, all the application of different packages to specific periods, and we can compare the outcomes of different strategies. So the model would produce a picture. If we had to look at the intervention mix with the associated reductions in R, so I'm assuming a starting point of 2.43 for R because we're in a warm climate, and then various interventions with each associated with a reduction in R. And as more evidence becomes clear, one can harden those kinds of assumptions. But you've got normal behavior in a hot climate, border screening and advice, closed borders, social distancing, employer protocols, a targeted lockdown, and a generalized lockdown. You can have targeted testing and contact tracing and mass testing and contact tracing. So those are all intervention alternatives. You can combine them into intervention packages So you would now say we've got a level 4 general lockdown with targeted screening and cold weather, and you decide which one of those interventions is in place, and you come up with an aggregate reproduction rate. And then in building the scenarios over the entire year, you would look at which packages in which period which you can apply by day. So this is within the model itself. You would select, this is three strategies that are just reflected here, just a few of the dates. And you can have no intervention, warm weather, limited intervention, warm weather, general lockdowns, and on the going down here, you can quickly see what is happening to new infections based on which scenario is active at that time.
Alex, can you try and wrap in the next 3 minutes, please?
Yeah, I'll do that. So, so in essence, you have the different scenarios. So this, I'm not going to go through them in any detail. So this would just go through what the scenarios are. But and I'll run through to the main scenarios quickly because of the limited time. So if we had to look at two main scenarios that have analyzed, one is what I call a lockdown dependent scenario, which is where we attempt to suppress the epidemic purely with lockdowns. And this just gives the curves associated with the assumptions that we used at the time. So there's a lockdown, then there's a withdrawal of the lockdown, and with a slight withdrawal, then a lockdown for a longer period, which suppresses the epidemic, and then a lockdown when the resurgence occurs. So there is multiple waves that is in this analysis. Out of this, we generate about a requirement for about 193 days of lockdown if we were going to suppress the epidemic exclusively with a lockdown strategy. The alternative strategy is a risk-adjusted one, where you use mass screening and testing as your alternative, and you could, although it doesn't look like it, the alternative, both alternatives generate very similar results in terms of overall outcomes. The difference is that there's a much shorter lockdown. So when this was generated, we were only looking at 35 days. So the assumption is that with mass testing and tracing, large parts of the economy are open. So then the comparison here is that with about 193 days of lockdown, if we were looking at that as a full lockdown, the effect on on the economy is very, very substantial. So the real issue here was comparing our alternative strategies that would be consistent with an open economy and seeing what would be the most efficient scenario. I will leave it there.
Thank you, Alex. Thank you for that. If we can go to the next presentation, I think it's from Bruce Malado. Bruce, if you can please put up your slides and start.
Can you hear me?
Yes, we can hear you.
All right. Trying to share. Okay.
Yes, your slides are up.
Excellent. All right. So I will dive into it. We're going to be dealing with a concrete question of the impact of non-pharmaceutical interventions, and we will end up with a prescription for policymakers as to how to transition from one level to the other within the framework that government has used for staging the release of the lockdown. So the basis for this work is looking at the data globally. We have a dashboard, an analytics dashboard that looks into the data every single day, calculates epidemiological parameters. And we've chosen about 100 countries and all the states of the US that have managed to generate a certain control or strong control of the epidemic via non-pharmaceutical interventions. And then we have validated our model, our mathematics, so as to accommodate those complex changes. Of course, the parameters are different for each country, but the mathematics is universal. All right, so that leads us to what we refer to as the dual SIRD model. That's documented here on the left. People can download it and we can get feedback from people. This graph here illustrates what the dual SRD model is. So after a lot of thinking and working with data, we arrive at the conclusion that if we want to minimize the number of parameters to have predictability, but want to describe the dynamics of the system, we have to divide it into two. One is what we call latent dynamics, meaning all those individuals that get infected but don't feel it, they are asymptomatic but can pass the virus to other people and then recover, leading to what people refer to as herd immunity. Because those folks are going to pass the virus to other people, we see basically an observed dynamics, which means that the number of cases of people that are going through the healthcare system, and that leads to reported cases. So essentially, we have two systems that are talking to each other and have a slightly different dynamic that we need in order to explain and predict what happens in terms of what we see, where herd immunity is very important. So of course, the model has a number of parameters, but two are the most important ones. One is what we call a stringency index, which is an adaptation from indexing performed by Oxford in the South African context and in the light of the 5-level alert regulatory system that I will talk about in a minute. And it basically quantifies social distancing imposed top-down. Alpha is a parameter that basically speaks to the efficiency of the non-pharmaceutical interventions, and it can be interpreted as how much people adhere to social distancing. And of course, the bigger it is, the better. And this parameter, because of the complexity of the system we deal with, is typically extracted from data. As a result, the model is semi-empirical. And the idea basically was here to look at all the data globally and South Africa, first during the time of pre-intervention, before lockdowns, where the spread was fast, and then observe and quantify and model what happens as the spread slows down. And that also includes South Africa. So I'm not going to go into details here. This is a sophisticated Markov chain using Bayesian implementation of the model, where we are able also to extract, as you see here, the latent infections, or essentially the herd immunity, which I think is an added value of this model. All right, so let's go to predictions for South Africa and the South African context, and that starts with us going through the complex matrix that parameterizes the different 5 levels. Each level is composed of a number of measures that government has issued, and these are classified according to the table that you see here in the bottom right, ranging from school closures all the way to banning of international travel. And going through this complex matrix, you basically end up having what we refer to as the stringency index, which is what you have in the upper right corner, where black corresponds to level 5, and then you go respectively to level 4 through level 1. The different steps, you see the small steps you've got here, that basically has to do with the fact that schools will be reopening gradually, and that is basically quantified by the fraction of students that are going to school. And also we had a very detailed analysis of the fraction of the population in the workforce that is going to work and is not going to work, and that's also parameterized in there. All right, so these are numbers that the importance of which are not to give you the value of the peak. These are numbers that basically assume 25% of the population having some level of symptoms. This does not speak to the needs for hospitalization. Obviously, the overwhelming majority of people will have mild symptoms that won't require hospitalization. And I will refer to colleagues that have spoken before me as to that question. The important thing here is what is the interplay between the non-pharmaceutical intervention and the social adherence to social distancing, and how that will play out in terms of when the peaks are going to happen and the relative amplitude of them. So what we have here is a graph before we started getting data in May, and I will show data from May, where you see basically that had we stayed on level 5 and with the same level of adherence to social distancing, the peak would have probably have occurred in November. Level 4 will be moving it forward by a month or so, and so on and so forth. Now, this assumes, this is very important, and that has been alluded to by other speakers, that the level of social distancing is coming from before lockdown, which was, of course, very loose. This is obviously a very pessimistic picture. So let's look at the data. Because the importance.
Try and wrap up in the next 3 minutes, please.
Yes, thank you. The importance of a model is not whether it is wrong or right, is whether to compare to the data to understand the dynamic of the data. And when you see here in the Gauteng province, here the data seems to be undershooting what would have been level 4 if social distancing had been at the same level as before lockdown. Meaning that it seems evident, or there's a hint from the data, that the population seems to be adhering to social distancing much more seriously than they were before lockdown. As a result of that, we are significantly lower than this dashed line here. Let's focus on the red, which is basically level 4. The impact, in order to bring this level 4 curve to the data, we need to enhance alpha by 20%. So that's roughly the empirical estimate of how much social distancing is adhered to now compared to before lockdown. The importance of social distancing and adherence to social distancing is exemplified here. This is numbers of active cases for Gauteng for different assumptions of small increases of social distancing or adherence to social distancing, where a 20% will basically shift the peak by about a couple of months. That's a very important factor in we want to control the epidemic. Now, let's move on to the practicality of this for policymakers. So based on this mathematical apparatus developed, we're able to arrive at an equation, in particular an inequality that tells us what is the criterion for a province or an administrative unit to go from one level to the other. We need to give a mathematical answer, a quantitative answer. Now, this may sound gibberish to many, but basically the important thing here that can be approximated to is that the relative increase of adherence to social distancing, so the improvement on how well or how we adhere to social distancing, has to be greater than the change in or the decrease in the stringency of the lockdown. Okay, if that is not the case, then we're basically going to go to very fast increases and not going to be able to control the situation. So in terms of what we showed for Gauteng, the equation for Gauteng looks like the increase of adherence to social distance is about 20%, which is greater than the what's going to happen when we move from level 4 to level 3, which warrants the transition to level 3. And that's the algorithm that we offer to policymakers for different administrative units. So let me conclude here. So we've developed a dual SRID model that allows us to predict the visible dynamics, the number of cases that the healthcare system sees, but also herd immunity, which is very essential for the future. We've developed a complete stringency index for the South Africa's 5-level alert system, which parameterizes the impact of policies on the spread and social distancing. We are providing, we have a practical recipe for policymakers as to how an administrative unit can move from one level to the other. And we've used Gauteng as a showcase. We're working with clinicians, of course, of the Gauteng Department of Health to showcase the fact that Gauteng, as per today's numbers and as per the last 3 weeks, seems to be ready to go to a lower level, level 3. Thank you.
Thank you very much, Bruce, for that. I think the more details will be in the rest of your slides. If we can go to the next presentation, understand it's Nick Hudson. Nick, hope you're here.
Yes.
If you are, if you can please load your slides. Thank you.
Anban, we only received notice of participation in this a few minutes before the event, so I don't have a stack of slides ready. So I'm just going to speak, if that's all right with you.
Sure. Yes.
Thank you. Just by way of a quick introduction, PANDA is a multidisciplinary team that is working to inform policy with respect to the epidemic, not just in terms of modeling. We probably came to some people's attention in pursuant to our paper on the loss of life that we thought might arise from lockdown per se, as opposed to from the epidemic. And the conclusion in that paper was that an important policy consideration that was being missed was that lockdown would have long-term impact on mortality via the extreme economic contraction that was evolving. Aside from that, we've also been doing quite a lot of work on the projections of the pandemic and the features that describe its evolution. And we're getting to answers that are quite different from everyone else. The first point of departure of our work was that we noticed that 7 key corollaries of...
Be careful, if you drop that, it will break.
You can please mute your mic. It's interrupting.
How do you know?
The first observation we made is that 7 key corollaries of the standard SER models that were being deployed were being consistently and persistently violated and had been since very early on in March. I'm talking now not just with respect to South Africa, but with respect to other countries. And I won't go through all 7 of those given the 10-minute slot that we have, but one that stands out in particular at the moment is that all of these models predict resurgences. You've heard the word resurgence many times this morning. And in particular, resurgences upon the lifting of lockdown. And that has not been observed anywhere. So we've taken a different approach. Instead of trying to build yet another SEIR type model, we have taken an empirical distribution approach and focused our attention on assessing explanatory factors for the huge differences between various countries' experiences with respect to the epidemic. I was very pleased to hear Barry from ASA talking earlier about how they were paying attention to that fact as well. We think it's a key to getting an approximate feel for what might happen in our future here in South Africa. The key findings of that empirical process at the moment are as follows. We are expecting a much lower deaths in South Africa than elsewhere in the world, modulo an adjustment for our much younger population. And we are expecting a peak in daily deaths much earlier than is being suggested by the SEIR models. Just as a data point there, of the 66 countries worldwide that have peaked, fully 56 peaked in a very tight range of 50 to 80 days after their first death. Now, when we look at that data, a very interesting feature emerges that the timing of that peak is completely independent of the stringency of lockdown. This is a very important finding, and we think we will explain just now why we think that the R0 evolution is being misinterpreted by the SEIR modelers. But let's just stick with this situation for the moment. What we're saying is that there is no correlation between lockdown stringency and the number of days to peak. And that is being found, it's a result that pertains regardless of how we measure lockdown stringency. So whether we use the Oxford time series, which will be very familiar to everybody, or whether we use cellular telephony information to measure actual changes in social distancing, we don't see any impact of lockdown. We just to try and unpack that a little bit, what we think is the missing link and what is being missed in the SEIR analyses is that there appears to be a large portion of all populations worldwide that is simply not susceptible to developing severe infections or serious infections of any sort. So these are people who would possibly never even test positive on a serology test after exposure to the disease. In other words, what's happening is their cellular immune systems, their T-cell systems are doing the job of keeping the infection at bay, and they never come up as cases or even infections in serology tests. And if there's a very large body of such people, what you'd expect is, in fact, what's observed. No resurgence after the end of lockdown. Serology tests that cap out at a 25 to 30% level, which has been observed everywhere. And a number of other things, which I'll just, I'm going to move on just to try and stay within the time limit. But if that's all correct, then models that assume much higher herd immunity thresholds, much higher attack rates, much higher ultimate prevalence rates or equilibrium rates, depending on how the models are articulated, all of those models would misread the approach of an actual lower threshold as a reduction in R0 owing to whatever intervention is being assessed. And we think that's a real problem at the moment, and one of the reasons why we've been sitting here today looking at projections that flatten out dramatically, which are in complete opposition to our empirical finding that lockdowns do not result in any kind of flattening or delay in peak. So that's the sum total of our overview. We would very much like to engage with modeling teams. We are very open to doing that and to discussing and sharing our results. We're not selfish about them at all. We just want the right answers to be found. And I think it's just very important at this juncture that we not start repeating the mistakes that have been made in other countries with massive overestimations of deaths and also of the duration of the peak. We are asking, all of these models presented today are asking South Africa to behave in a way which no other country in the world to date has behaved, and to a level much more serious than the most serious countries that have been observed on an age-adjusted basis. And we think that's a big problem. The stakes are enormous in this game, as our paper earlier in the month showed. The consequences of lockdown are a vast humanitarian crisis in and of themselves. The causes of that are well understood, and we have to be very careful not to use models that are inconsistent with the reality that's emerged elsewhere in the world and that cause us to stay in a lockdown situation that has terrible consequences for the population of South Africa. We have to remember that poverty kills as well as viruses.
Thank you very much, Nick. Sorry that you had short notice, but we appreciate the input. So those were the presentations around the intervention models. Now we're going to the last set of models, which are related to spatial modeling. And here, I think Pierre George is doing the first presentation and Zaid and Kimi thereafter. So if I can ask Pierre to start his presentation, please.
Hi, everybody. I hope you can hear me and see the slides.
Yes, we can hear you and we can see the slides. Thank you.
Fantastic, thank you. So I'm going to have a bit of a change of pace to the previous models. The previous models have all been top-down models, while we are building a bottom-up model. We've built SABCOM, the spatial agent-based COVID-19 model, which is joint work with Alan Davids, Ridian Duran, Tina Koziol, and Yuri Skarsford at UCT and Stellenbosch. So the big issue that a number of the speakers have raised before is that the SEIR top-down models critically depend on the dynamics around the reproductive rate R0. They aggregate by the very nature of the model over large spatial areas, be it in a compartmentalized model or in a nationwide model, which is probably fine in countries like Germany or South Korea, but in a country like South Africa, which has one of the world's most unequal societies, the spatial aggregation comes with an inherent problem because the dynamic of virus transmission is very different on the left-hand side of this picture than on the right-hand side. The other issue with these models is that they move a lot of the complexity into understanding the impact of policy measures on R0. A lot of that impact is difficult to estimate, and therefore we have taken a quite different approach to this problem. In our model, we model from the bottom up. We have three levels. We have agents, individuals, humans. They are distributed within wards, but according to different densities, in line with what we actually observe in census data. And each ward has their own internal structure, and agents are allowed to travel between wards, again, calibrated from travel data that is available for Cape Town, which we use as our baseline calibration. So in this model, you have in the first step some agents that become initially infected, maybe because they have been traveling to Europe and return back to Cape Town. So this one agent becomes infected, and the two that are closest to him are susceptible. Now, one of two things can happen. One of the susceptible agents can travel, possibly putting other agents at risk, but there is no sort of immediate transmission of the virus. Or you can have less luck where the infected agent travels, actually infects an agent in his own ward and travels to a highly densely populated ward where he further exposes other agents that he interacts with. The model that we have is a network-based model where we have explicit social interactions within different wards calibrated to the features of these wards. And this approach allows us to include explicit adaptive agent behavior. So in our model, for example, agents choose to self-isolate if they have been exposed with a certain probability. This makes the model from a agent, from an individual perspective, sort of more realistic. And the goal is that the model results that we produce in such a model will eventually converge with the model results from a top-down approach, so that we have two completely different methodologies resulting in the same insights, which eliminates all systematic errors that the SEIR models might have. So our model, the dynamic on the local agent-to-agent level is quite similar. We have the basic SEIR transmission probabilities calibrated to the best available data and parameters. Once you are infected, you can be exposed, then asymptomatic or symptomatic, from where you might move into critical or into recovered, and from critical into recovered or diseased. This allows us to study also questions around hospitalization and questions around sort of ICU capacity. We have calibrated our model for Cape Town because that's where we have the best available data. We use the pathogen parameters from the best estimates in the literature, and I'm very grateful to the colleagues who have emphasized the large uncertainties that these parameters still have. We have a number of simulation parameters, but we also use data that is easily observable, like census data, National Household Travel Survey data, and data from the Western Cape Department of Health on initial infections, ICU beds. And lastly, we have a set of policy parameters covering sort of lockdown level and alternative policies. Based on this model, we can compute estimated number of infections per ward over a certain time horizon. And this gives us an understanding of the spatial dynamics of this virus so that we can target lockdown levels and sort of restrictions based on the specific needs of a ward, as opposed to a highly aggregated level where we have the same restrictions applying to an informal settlement and from a very affluent area. So what we can produce with this model are different ward level predictions over time. And you can see in these, I deliberately haven't labeled these wards. You can see that the dynamics in different wards is really quite different depending on local density, age population, transmissibility on an agent to agent. From this bottom-up approach on different wards, we can then construct sort of the aggregate data, in this case for Cape Town, and we can study sort of different effects of interactions within wards, so the local social interactions and policy measures directly targeting these local social interactions versus travel restrictions, for example. One of the things that we find is that indeed the within ward interaction seems to be the main driver of transmissibility, and that's a lesson that I sort of want to sort of dig a little deeper into when I talk about alternatives, because the key feature and the key advantage of a bottom-up model is that it allows us to study policy measures in more detail. So specifically what we have done is we have looked at various sort of policy measures, and we've looked at if we change this policy measure. So if we say, for example, we have a travel restriction, how strict is this travel restriction for an individual agent? So do we have roadblocks on highways? Do we restrict travel to within a ward, or can we be a bit more lax about the across-ward restrictions? You can study the effect of what the change in this multiplier does to the total number of cases that are infected. And the key takeaway lesson that I want you to have from this slide is that there are some policy parameters where if we change them by 10%, the change in the number of infected cases is also around 10%. There's a linear relationship. However, there are some policy parameters where a small change in the policy parameter can have a significant and large impact on the share of the infected population. And the one that I want to focus on is the close contacts multiplier. So how many people are you in close contact with? This seems to really drive the transmission probabilities. And when we study why that is, and our model allows us to sort of dig deeper into the per ward sort of dynamics, we can see that for the 116 wards in Cape Town, when we plot the total infections per 100,000 individuals over a large number of simulations, given the best available parameters, we find a striking relationship with the density per square kilometer. This again is an impetus for policymakers to think about de-densification policies, which has been discussed on a national level, and it seems to be a main driver of the results. So some of the parameter changes are really crucial, and in particular, the close contact multiplier seems to play a crucial role. This is again motivation to look deeper into how can we understand these close contacts. So the second takeaway I want to leave you with is that effective contact tracing is absolute key. We need to understand close contacts in order to be able to intervene on a bilateral agent by agent level, isolate cases that have sort of initial symptoms or where we see an initial outbreak. And the second part that we've done, aside from building this model, is we've built a track and trace solution that specifically targets the South African reality where people don't have smartphones. More than half of our population doesn't have smartphones. So any Bluetooth-based contact tracing solution will be inefficient, because we know from research coming out of Oxford University that in order for contact tracing to be an efficient policy measure, you need to identify 60% of the contacts of at least 50% of the people who actually have the virus. So it means this track, trace, and treat is really key. You first need to identify the cases that are positive through additional testing, and then you need to have an inclusive model of track and trace that tracks down all their contacts to isolate them individually. And the platform that we have built is called COVID-ID. Everything we've done is open source. So you can go to, I have the links at the end to our GitHub repository, download our code. We have all the calibration files and all the data that we've used that we can put out in the public. We have included there. So this is just to increase the reliability of the model. And the same is for the platform that we've built. We work through a QR code system.
In the next 2 minutes, please.
Yeah, I can. So we've built a QR code system that allows users who don't have smartphones to still be included in track and trace solutions, which no other technology can give you, but which is something that is particularly important in South Africa. We've developed this together with a team at MIT that has built COVID-safe places and COVID-safe paths to have an enterprise solution for public health officials, which is all, as I said, it's all open source. It's completely free. It's a solution that works in the South African context and that can augment existing track and trace solutions. So if you're interested in sort of talking more about the modeling assumptions and sort of the policy measures that you can derive from this model, as well as the practical solutions on how to address these challenges, to have alternatives to a national lockdown, then we are keen to engage further. And with that, I think I'm on time. Thank you very much.
Thank you very much, Pierre. Thank you for sticking to the time. If I can now ask Zaid to load his presentations, the final presentation on spatial modeling. Thanks, Zaid. We can see your slide or your Excel sheet, actually. Zaid, please unmute. We can't hear you.
Okay. Can you see the first page of the slide presentation?
We have an Excel sheet that's showing currently.
Okay, sorry. And now?
We still have the same Excel sheet that's showing.
Okay, sorry. Let me just try and sort this out quickly. Sorry, I seem to be sharing the wrong thing, but I can't switch it off at this point.
I need to unshare and reshare.
Okay. Okay. Is that better?
Yeah, now there's a slide that says COVID-19 spatial model, May 2020.
Okay, great. Thank you very much. I'll go through this reasonably quickly. This is a spatial model, and some of the colleagues have already spoken about why spatial models are important. There's a team that's assisted in putting these together. They're listed there. I'm not going to read through the names. So we've already mentioned that one of the problems with these compartmentalized models is that they assume, as Co-Pierre has already pointed out, that there's homogeneous interaction, that every person in the model is equally likely to interact with any other person. And of course, as we know, this is not true because that interaction is spatially constrained. People in the Western Cape don't interact freely with people in Gauteng, and people in some wards don't interact freely with people in other wards. And why we need a spatial model, so also people have already explained, is that the spread of the infection will differ across different spatial levels, by province, by national, municipal, and by ward. And that we'd want to predict both the timing and the scale of the demand in the health system at finer scales. And finally, we'd also want to make predictions early in the infection about where new infections are likely to occur. So what we need to do, and Co-Pierre has demonstrated one version of a spatial model, which is to use an agent-based model. I'm going to talk about something that's an intermediate, where we'll use a different level of spatial aggregation. And we're going to use the ward level. And in order to run a spatial model, firstly, we need an SEIR model that we can apply at ward level. And that's just an input into the spatial model. We need some way of understanding how people move between wards. And preferably, we want that movement data to also reflect what sorts of interventions have been imposed. And I'll give an example of what that movement data can look like. And finally, we have to have some way of taking into account the interaction between that movement and what the SEIR model is saying. So I'm just going to give a little sort of play example here. Here, as an example, if we only had 5 wards in our system, what we can do is apply an SEIR model at each ward. And if we apply that SEIR model at a ward level, we can adjust the model parameters to take account of local factors. So if you were running a model at a national or provincial level, you'd have to make global assumptions about the population structure, about movement, about the effect of climate at that scale. If you're running the model at the ward level, you can adjust your model parameters to take into account various things. The age structure at the ward level, the possible effects of climate at that small scale. Some of the other speakers have spoken about what the effect of winter is, for example, as well as the effect of population density, access to service, etc. So all of those can now be applied at that smaller scale. At each time step, if you're on that SEIR model, you have to decide if there are new cases in that ward, how should they be distributed within that ward, and how should those cases potentially leak out to other wards? One way of doing that is to just say if by a measure of distance, but what we're using is aggregated mobility data. And I'll give you an example of that, to export cases from our initial ward to every other ward. At the same time step, all of those wards, of course, export their own cases to your initial ward. So what you have is a whole process of running these models at each ward and then summing up how cases were exported and imported across all of those wards. And that at every time step is now the at every time step gives you a new set of initial conditions for each ward. There are two sources of variability in this sort of model. That spatial spread is stochastic, not deterministic. That every time step, we don't say that every infection spreads absolutely in the following way. We use the mobility data to say how likely it is that the infection will spread. And of course, the second level of variability, yes?
Thank you very much. We are part of you, Anglo.
Sorry, there's someone.
Thank you very much.
Sierra, can you please mute your phone? Can you mute, please?
Okay.
Thank you for an excellent.
Sorry, and of course, the second source of variability is that the SEIR model parameters themselves are subject to some uncertainty. So in order to get a decent sense of what's happening, you have to run multiple iterations of the model to spread that stochasticity over both the spatial spread and what the model parameters say. This is just an example of what that mobility matrix would look like. And it gives you an estimate of what proportion of people in each ward was seen in every other ward. This data is provided by Vodacom, and it aggregates movement data per day across all wards from early March through to basically today. So on a daily basis, we're able to get what proportion of people in each ward moved to every other ward in South Africa. And just to give you another example, this captures movement patterns, and we can see what the effect of those movement patterns, what the differences in those movement patterns are across various levels of interventions. So between the 2nd and the 15th of March, we had no intervention. We then had social distancing, lockdown, and level 4 lockdown. And here's an example. If we use the movement patterns from the pre-intervention phase as a reference, so what has been the difference in mobility from that pre-intervention phase? And we're looking just at two metrics here, that should be 10 kilometers, movement for more than 10 kilometers and movement for more than 50 kilometers. So under no intervention, we set that as a reference value of 1. And we can see that under social distancing, the level of movement across those two metrics decreased by 10 and 5% respectively. And under lockdown, the movement decreased by 40% and 70%. And we can see up to the present day what the effect has been under level 4 lockdown. And this gives us a sense of what effect movement is having on the spread of the virus. So what do we have at the moment? We have this spatial model implemented on the Center for High Performance Computing, who've very generously given us the space to play around with this. We're able to take into account local vulnerability measures and the effects of climate. And the model allows you to turn these on or off. We can produce estimates of numbers of infected at ward level, and the outputs can be aggregated to district, municipal, and provincial level. And going forward, we can account for differential implementation of interventions at different spatial levels.
No, but who told them you wrap up in the next 2 to 3 minutes?
Yeah. We can have different lockdown levels for different time periods and for different municipalities.
No, wrong with
I'm very sorry, Anban. I'm sorry, Anban.
Yes.
You've got a number of people who have got their phones not muted and interfering with this. We have the names. Please ask them to mute. Otherwise, we're going to have to call the names because we can see who's not muted.
Yes, please.
As a result of hearing a background from the back, and it's disturbing the presentation.
Please mute your phones, everybody. It's only the presenter that should have the mic unmuted. Thank you.
Okay. And we will have to call the names because we can see who's doing it.
Okay. All right. I'm just going to, so I think the key thing about the spatial model is that you can also then project what your scenarios are or try and model various scenarios that have different lockdown levels at different spatial levels. So a particular municipality could go to lockdown level 3 for the next month and then lockdown level 2, while other municipalities move to level 5, etc. So in order to get that granulated detail of what the effects of different strategies will be. Just to give an idea, you've seen this sort of picture before. That's a different epicurves drawn for different provinces. This would be just if we restrict it to the Western Cape, and you can see what the effect of the city of Cape Town is relative to those other municipalities. And this is just a picture of the municipalities in the Western Cape without the city of Cape Town. So that we can then do these sorts of curves at ward level as well as municipal or district level. The other sort of output that I mentioned at the start is, are we able to predict what the spatial spread of the virus will be? So just as an example, if we initialize the model on the 1st of April and we ask it to predict what are the high-risk wards on the 21st of April, we can compare that to what the actual outputs are. And this is just an example. I've taken out the ward IDs, but just listing, for example, the 100 most high-risk wards, and then indicating which of those wards actually reported positive test infections. These are wards that at the initialization date did not have an infection, and we're looking 21 days later, the comparison between what the model predicts and what the outputs are. So just on this base level of the model, we get a very high level of precision, well, relative to chance, that 64 of the highest risk wards that had no infections at the initialization date did show infections 21 days later. But the model at this stage isn't very good at the opposite side of that coin, which is predicting exactly where it will spread. So it does a fairly poor job of saying which wards, of predicting the total set of wards that will become infected. But it does a reasonably good job of identifying wards where it is likely that infection will occur with a reasonable level of accuracy.
Zaid, please try and Thanks. Thank you, Zaid. Thank you very much for trying to keep to time. We've reached the end of the presentations, and thank you to the speakers. I'm sorry that we had to put you under pressure in terms of time because we don't have too much of time. There were so many presentations. There were others that we had actually could not put up today, given the time constraints. I'll now hand over to Dr. Loazi Manzi, who's going to be managing the Q&A session.
Thank you very much, Dr. Pillay. Colleagues, unfortunately, time is not on our side. So if I can ask that those who would like to ask questions raise their hands. We won't be able to probably take every single question. You may raise your hands digitally, please, as I do not see. Okay, I have at the moment 2 hands, 3 hands. Can we take 5 hands for now? And okay, we'll take these first 3 hands. We've got Simone, Pravesh, and Kyle. If we can start with Simone, please, followed by Pravesh and Kyle. We'll take those 3 questions. Please do try to direct your questions specifically to the modeler that you would like to ask the question of. And please do try to limit your questions as we do have time against us. Thank you very much. You may unmute yourselves and ask the questions.
Hi, it's Emil here. My questions are directed to Professor Alex van der Heeven. Just based on the model, I'm very interested in it. The model uses intervention successes in other countries and assumes we should get similar results in South Africa. But then you then admit that we have not been getting those similar results. So then how do you negotiate your conclusions there? And then as an extension, you use Italy and South Korea as examples. But in South Africa, our dynamics are vastly different. How do you form the basis of this comparison? And just going on, you conclude with 2 scenarios, that 193 days of lockdown or 184 days of mass testing and screening. What evidence or factors do you use to come to such specific conclusions? And if I can just go on from that very quickly, I was reading up a column that you wrote a few days ago, News 24, and just based on what you've presented here today, You said in the column that future generalized lockdowns are also not feasible. But one of the conclusions in your model presents a 193-day lockdown that brings the infection rate all the way down. How do you explain this? Is this a contradiction? And you've also previously criticized in that column government for testing 3,000 to 5,000 tests per day, saying that it needs to be closer to 20,000. Yesterday, government shown that they've gone up to 18,000 tests in the past 24 hours. Have you taken this rapid increase of testing into consideration with your modeling? Thank you.
Thank you, Simone. So before Pravesh continues, I see that we do have two more hands. We've got Karima and Catherine. We will actually, if we can try to take all the hands. So if you do have a question, please do raise your hands now. We will acknowledge that you have raised your hands. Once I have, you can please go ahead and take your question. So we now have Pravesh, Kyle, Karima, and Catherine Child. If you can please just, as soon as the person before you has asked their questions, you can go ahead. And if you have asked your question, please do lower your hand so that we know that you're done. Thank you very much.
Okay, thanks very much. This is more a question for Anban, more than the speakers, because this is a really good session. I think most of the models really appreciate the open discussions and stuff like that. And one of the ways of taking care of uncertainty is by looking at various different models and trying to see how we can come to some sort of agreement as to how one can combine these different models and stuff like that. So in terms of moving forward with these kind of discussions, and because there's many other models, and as was also mentioned as well, that people are doing, what opportunities are there going to be in the future for others to present and models to be discussed in a more open way? But really, thanks for this session.
Good morning, Kyle Cowan from News 24. My question is for Professor Julia Quilliam. Prof, in the very last slide on your conclusions, you mentioned that approximately 12 to 13 million symptomatic cases projected by the beginning of November with the accompanying hospitalization requirements. Can you just please walk us through, in your model, the difference between your active projections, your projections for active cases and your projections for detected cases across that same timeline? Because there seems to be a difference between those, and it's not coming across very clearly. Thank you.
Thanks, Kyle. Karima, you may proceed.
Hi, I wanted to ask of all the modelers the question around screening and testing, particularly screening, mass screenings. How do you ascertain, whether people are testing if so many people are asymptomatic? I think one of the modelers pointed to something up to 75%. So I just want to know how you, determine the reliability if screening is one way of getting to the numbers if so many people are said to be asymptomatic. And then just the other question, I can't remember which modeler it was, but there was a presentation that was based on herd immunity. I watched a World Health Organization briefing a few days ago where the herd immunity concept was roundly cautioned again and discredited. I just wanted to know if the health department is factoring in the World Health Organization approach to herd immunity, or whether herd immunity is something that is informing modeling and the control mechanisms that are being considered. Because the problem here is that when people present numbers and data, they are not declaring their worldview. And it's very clear that epidemiologists have different worldviews. There's herd immunity, there's the lockdown approach with gradual opening, and then there's the Wuhan, China model of a total lockdown and isolation of people on a mass scale. So if we can get a sense of what kind of school of thought people are coming from, then one is able to engage with the data from a much more informed perspective.
Thank you, Karima. Catherine, you may proceed. If I may just ask Karima and Simone to please lower their hands.
Hi, this is Catherine Child from Financial Mail. I have a question that is for both Prof. Pulliam and for Barry Childs of the Actuarial Society. What is the purpose of your models? And the reason I'm asking is that both of you have said repeatedly there's considerable uncertainty. They could change many times. They could be too high or low. So if you can't kind of predict or forecast with any certainty, why do the models? Because there is a reason. And then could you both confirm that I've understood you right? I'm a layperson and I may have misunderstood. Both of your models assume that social distancing and non-pharmaceutical interventions do little to change the R0. So no matter what we do, the infections continue. Can you just confirm that and why? And then lastly to Prof. Pulliam, you're assuming 13 million infections. Is there anywhere else in the world where a quarter of the population has got infected within 6 months? And if you strip out kids, that's like 1 in 3 adults by November. Is that seen anywhere else? Thank you.
Thank you, Catherine. Please proceed. Marcus, Catherine, please lower your hand.
Hi, it's Marcus Lowe from Spotlight. My question is for Professor Pulliam. You say that your mortality estimates assume unlimited ICU capacity, but you also specify that there are known thresholds to how much capacity we have. So what estimate do you have on the number of people who will need ICU beds who can't get ICU beds based on what we know currently about capacity? Thank you.
Thank you very much for the questions. Colleagues, I do not see any other hands. I'm going to give one more minute of opportunity for any further questions. If you would like to ask another question, if you have already, now's your chance. Otherwise, if there are no more hands in the next sort of minute, then we will actually close and I will ask those. Okay, I see 2 hands coming up. One more chance, 3 hands, 4 hands up. Right. Okay. And now it's only 3 hands. Okay. Going, gone. Right. So I have Ibrahim Sidat, Dr. A. Gavita, and Eugene. You can please go ahead and ask your questions. Once you have, please lower your hand so we know that you are done with us. After these 3, if there are no other hands that do come in the interim, we will then close the questions and we will allow for the respondents to respond. Thank you so much.
Hi, good morning. Thanks. Just a question on the projections. Currently, Italy, Spain, France, UK are all roughly under 300,000 cumulative cases. That's over, however you want to count it, 12 weeks. Let's say, let's be conservative. If I just eyeball some of the graphs published yesterday, it looks like you're saying by mid-late July, we'll have 1 million symptomatic cases, whether cumulative or active. Doesn't matter because the number is so big. So which other countries are we going to climb in 10 weeks 4 times the rate of Europe, given its northern hemisphere, older population coming out of a weak flu season, which spared a lot of normal flu deaths, et cetera, it's just very puzzling that, and that's obviously the takeaway that's been in every media article since yesterday, causing very great concern. And in that regard, I'd like to ask Nick from Panda, because it seems some of your points are quite in line with the real data-driven stuff that Michael Levitt's pulling together with his kind of crowdsourced team. So, could you shine a bit further light on some of those projections? Because I find it very hard to believe we'll be 4 times Northern Europe, all those countries at kind of 40 to 45 latitude. And if you look at Gauteng, look at Pretoria at 25 latitude, very clear, a sunny, cloudless winter, 1,400 meters altitude. Look at our numbers, right? 3 deaths, under 400 cases, et cetera, et cetera. so I just like some some nuance back, because I can see everyone is trying their best, quite sincere, etc. But it doesn't seem there's like a reality check with the real numbers, in kind of global hotspots. Thank you.
Yeah, Ibrahim, it's very interesting. We couldn't believe it when we heard Mike Levitt start speaking, because there was an almost 100% correspondence between his perspective on how this epidemic progresses and ours. We still have to work out who's been spying on whom, but he's got the Nobel laureate, so we're probably the spies. But the points you raise are on the button. The problem we find with all of the models is that on an age-adjusted basis, South Africa should have quarter as many fatalities as Italy, which would mean about 10,000. And we find that like a sort of a very good anchoring place. From there we can move. From there we need to ask, is there anything unusual about South Africa? We need to consider carefully the HIV situation, the tuberculosis situation. And so what we've done is focus on little tests, little signals that we might be able to use to detect whether there's anything unusual going on in South Africa. And so far there isn't. We're getting exactly the right distribution of deaths by age, meaning 40% below the age of 60. That has been very stable since the numbers hit 100 and is still stable today, which is great news. It means that there's not a sign of anything that causes the age distribution to change, which would be a huge sign that there was something unusual, something sui generis about the South African experience. So I hope that answers your question.
Thank you. I'm sorry. Thank you very much for the answer. I'm going to just ask that the other two, there's also a third question that's been typed in, complete their questions, and then we'll ask everybody to answer at the end. Eugene, please go ahead.
Yeah, thank you. Thank you very much. And thank you, colleagues, for a good presentation. Eugene Kluter speaking here, Stellenbosch University. And I'd like to add on to just the answer of the previous speaker. There are two things I miss in terms of the models. The one is that age is not factored in. If we consider that as of today, only 18 people died under the age of 40 years. Only 18 under the age of 40. Now, our population under the age of 40 makes up 71.6% of the South African population. Except for a premature baby that passed away this morning, there's been no death under the age of 20. I'd like to see that factored in a little bit more of a granular fashion in the models that are being presented. So that's the one point. The second point is that the modelers, whether they have tried to retrofit their models onto the data that we have today, that means rewind, go back to the first models when they were developed and retrofit them to predict what we see today and then extrapolate from there. Thank you very much.
Thank you. Dr. Gawanda, please do go ahead.
Thanks, Lwazi. I think Eugene asked some of my questions regarding the age. But my question, I'd really first like to thank all the modelers for giving us some insight into how the NCC and the Health Minister sort of responds. I'd like to know, as Eugene pointed out, if the National Command Council reviews the modeling based on the actual data that we are getting from South Africa in our case finding. And if so, how often is it reviewed? Is it a moving response? I think that would probably be answered by Anben or Dr. Mkhize.
Thank you, Dr. Gawanda. There was Sinesipho who had requested to type in a question. I'm still waiting for it to come through. And so I'm just going to ask that the presenters respond to the question so far. And when Sinesipho's question comes through, I will indicate. Thank you very much. Perhaps can we ask Dr. Anban Pillay perhaps to kick off for us with the responses that were directed to him?
Thanks, Dr. Manzi. I think there are two questions directed at me. The first one, I think it's important to highlight that there are many modeling groups. The ones that are presented today are some of the ones that we know. Provincial departments have also got modeling groups that are doing work for them. They didn't have an opportunity to present today. And each of the modeling groups have an opportunity to publish their work. I mean, we're not regulating who publishes the work and who doesn't. But I think certainly if you've got a model and you'd like to share it with us, we're very keen to hear about it so that we can see how we take account of the work you've done and the angle that you've looked at in terms of the modeling so that it can inform our policy and planning going forward. So yes, we certainly welcome that. On the second question about the work that's being done and where it goes to say that almost on a weekly basis, the modeling group shares their data with us, and we take that through to the NCCC as well as to the NAC joints, which is a joint structure of the various government departments that's chaired by the DGs of all of the departments. And so if there's any data, as I said, that people would like to share, we're welcome and keen to have a look at it. Thank you.
Thank you. Thank you very much, Dr. Pillay. Perhaps just to make it easier, what I will do is I'll just go through the list of presenters to see if there's any responses from anybody. So perhaps if we can ask Ashley if there's any response to any questions that were posed by the media.
Thank you very much. So as I mentioned in my presentation, I think what's absolutely key is our ability to continue to calibrate the models based on real-world evidence, but also to incorporate the ability to change some of the factors and how that influences the spread of the virus. So specifically touching on some of the screening questions and the success of track and trace, these are elements that we do need to focus on in order to measure the success of these programs, in order to allow us to ensure that the modeling as well as the projections stay in tune with those activities. Thank you very much.
Thank you so much. Just to alert everybody that we do have a time constraint, and I really do apologize for this, but if we can just quickly go through the answers, and thank you very much, Ashley, for keeping your answer brief. Barry Child, if I can ask you if you have any answers to the questions.
Thanks, Lottie. So just to answer Catherine's question, the NPI effects, yeah, I mean, we assume that there is a differential effect. We haven't, I mean, our model is not really an intervention model like some of the others presented, but there is a lot of literature on the potential differential effects there. That's not the core purpose of our model, which comes to your first question, which is we wanted to, it was clear that there was a need to do something for our profession. As I said, actuaries are interested in all things mortality and morbidity. That's a large part of what we do. And so when there's a sort of external force like this that has the potential to affect population mortality to any significant degree, we need to take note. So what we wanted to do was put something into the public domain to inform our members, to stimulate debate, and hopefully make a contribution to the national conversation. So far, we've succeeded in doing the first one or two of those. We're hoping that as we refine the models, we can continue to contribute to the debate. In terms of fitting to the data, the one concerning thing we've noted is that our model is lower on deaths than what we've currently seen, which could be because the structure of the model was pushing our peaks out too late. But we're busy going through that calibration process at the moment just to try to get a better handle on where we need to change and modify. Now that there's meaningful data being presented every day, it's easier to do this.
Thank you. Thank you very, very much, Mr. Child. If we can have somebody from the consortium answering some of the questions, please. Some of the questions that have not been answered, if possible.
Yes, thank you. So I'll first address Kyle Cohen's question. Thank you for that. I can see how it might be a little bit confusing with all of the different numbers. So the 12 to 13 million symptomatic cases is a figure that is the cumulative cases by the beginning of November. The difference between active cases and detected cases is that active cases are symptomatic cases that are active at a given point in time. So when you see on the x-axis time and on the y-axis the number of active cases, that's how many people are sick, it's symptomatic cases, so it's how many people are sick at that given point in time. And so the detected cases would be a subset of the active cases, and the total number of symptomatic cases is not directly something that you can pick off of the curve. The peak, as you will have noticed, occurs at about 1 million cases, but that's active cases at the time of the peak. And so it's in some ways it's sort of an integration to give the cumulative number of cases. So I hope I've clarified that. If not, you can contact me offline on that. Next, going to Marcus Lowe's question about the ICU beds needed. So our projections are that at the peak, there will be between 25 and 35,000 beds needed. Currently within the country, we have somewhere between 3.3 and 4,000 beds. And even as we are making efforts to increase the number of beds, there are other constraints that are important, including the trained staff, as well as the number of ventilators. But I think the staff is the most crucial constraint that we're facing. And then finally, in response to Eugene Cluta, I think our model, well, I know that our model does actually take into account the age, particularly with related to the case fatality and the infection fatality estimates that are available by age. I can't speak for the other models, but that is something that we take into account, as is what you were calling retrofitting is, I think, what the rest of us are referring to as calibration, and we do that regularly as well. Thank you.
Thank you so much, Juliette. If I may ask Alex van der Heever to please respond. There were some questions that were posed to him. If I could ask you to please be brief, 2 minutes if possible, please. Thank you.
Thank you. The question asked about the approach to getting the results that I had in the model. So there were 2 interventions that were sort of calibrated based on South Korea and Italy. At the time when the analysis was done, those were examples of key interventions such as lockdowns and testing and tracing as the core strategy. So within the model, the purpose was to evaluate whether if both of these succeeded to the levels that they did in those particular contexts, how many times would we need to apply those measures or keep them in place in order to suppress the epidemic during 2020, given that there will be a resurgence. So the model itself does generate a resurgence. So if you bring it down, it reappears and you squash it. So the main purpose of this model is to analyze suppressing the epidemic as opposed to analyzing what happens if we fail, which is when you're effectively looking at projections that go all the way to a natural sort of turning point. So in terms of the 2 different scenarios, then the purpose of what I call the lockdown dependent strategy was not to say that this is the strategy that's required, was that if it worked to the extent that it works anywhere else, how many times would we need to apply it? How many days would we need to have it in place at that extreme level in order to suppress the epidemic all the way through 2020? And to compare that to an alternative strategy, such as testing and tracing, which typically works only if the epidemic's at a relatively low level. If it gets very high, you can forget it. So if you see Western Cape at the moment removing their community-based testing program at the moment because the epidemic has essentially surged beyond their capacity for testing and tracing. The comment that the question was asked, why in the testing and tracing have been sort of critical of the fact that we haven't reached the levels sufficient to have a preventive effect. The preventive effect doesn't just come from the number of tests, it comes from how the tests are done and whether or not they happen, whether the turnaround is very fast and the contact tracing is very fast and that it's deep. In other words, you do trace all the contacts. If those features of the testing and tracing strategy are not in place, the number of tests is not an indicator of success of the prevention of the epidemic. So my concern with this is that actually our testing and tracing program at the moment is not at a sufficient level to contain the epidemic. And that's potentially why we're seeing some of the problems with what we have now. So the lack of success at the moment in terms of the lockdown it suggests that in fact our context is not the same as Italy, not the same as the UK, and therefore we need alternative strategies to be able to suppress the epidemic. The other option is to give up. So, and that's a contingency. So in terms of my analysis, I only have that as a contingency, not my strategy. So that's the purpose of this kind of thinking in the modeling framework, is to actually try and identify what's the most appropriate strategy and mix of interventions.
Thank you very, very much, Mr. Van Heerden. Bruce, I think there was one question that was for you, if I remember correctly. Bruce Malado?
Yeah, so two quick issues. So Karima made a very good question in regard to herd immunity. So herd immunity has two aspects. One is the modeling aspect, and the other one is the epidemiological aspect. So what we provide as modelers is the evolution and the quantification of the number of cases that we don't see that are asymptomatic. And then the epidemiologists have to answer the question as to what will be the fraction of those that will develop herd immunity or not. So that the only way to quantify herd immunity is to understand the latent and hidden dynamic and the number of people that are basically asymptomatic. And that's the advantage of the model. And a quick answer to Professor Eugene. I think it's best answered by looking at the age profile of mortality. So now we do seem to have sufficient data to be able to explain from first principles. This is not a fit or a regression to the data, but it is a prediction given the age profile of the South African population and the distribution of comorbidities that are taken mostly from Gauteng. We don't have data from other provinces, but it's doing a very good job. The blue is basically the actual data as of 2 days ago, and the yellow is the 68% confidence interval of the prediction, showing that there's a very good agreement between the data and the modeling, meaning that the modeling does take into account the age profile and the structure of the comorbidity in the country. Thank you.
Thank you so much. Pierre Georges from University of Cape Town, was there a question for you?
Yeah, about the age distribution. In our model, we have both the morbidity difference across ages, but also different sort of contact probabilities across different age groups, which you can calibrate to existing data. And I also want to add on what Alex started around the contact tracing. It's really crucial, and I cannot stress this enough, that we get our contact tracing right as an alternative to a lockdown. As soon as the system gets overwhelmed, I think everybody agrees we need to go into a lockdown. But there are regions where it's not yet overwhelmed, where we can reopen the economy if we have our contact tracing right. And at the moment, we don't. We are not fast enough and we're not deep enough. And the one thing that our models show is that this identifying close contacts is really absolutely crucial in preventing the spread of the disease. So I think that's a key policy lesson that comes out of the models that other countries have experienced as well, where we don't have a lot of disagreement, which is rare. And then lastly, I want to encourage the press to push us academics to make all our source code available, to make all our data available, so that there are reproduction files. It's very convenient for us to not do that. So I hope that the media will keep pushing to have access to the full source code and full reproduction files, because that's the only way that we can create the necessary public trust to impose measures other than a lockdown, so that everybody understands what needs to be done in order to fight this virus. Thank you.
Thank you very much. Zaid, you're the last one, Zaid Kimi. I don't know if there's any question that was perhaps left over that you might be able to pick up on.
I'm fine at this point, thanks.
Thank you very, very much. Thank you all so much. We can be here all day discussing modeling. It's a very, very interesting topic. But I would like to hand back over to the Honourable Minister to close this session. Thank you very much, Minister.
Thank you very much, Lwazi, and thanks to Anban. Thanks to all the panelists. This has been very interesting. And certainly I hope that members of the media found it just as interesting. And certainly sometimes even more interesting when you go to sit and listen to all the issues being examined from different angles. A few which I found to be also just interesting to make a few comments. The question that's been raised around the question of screening and the value of screening in the face of asymptomatic cases. I think we just need to realize that we follow the infection on the basis of the fact that there's a chain of contact. So whoever will have the infection would have got it from somebody. Now, in our case, when we go out with the screening, the chances of getting someone who has got symptoms and test them positive is a reality if the area in which you're also testing is an area where there's already been either contacts or positive cases found there. So part of what we had to look out for was that. But secondly, there are lots of asymptomatic people who have been tested. Those are the ones who are contacts, which therefore reduces the risk of the numbers of people that we can miss if you can find the asymptomatic one who are contacts and test them, and then find those who already have got symptoms and test them. Then, of course, that means that there will be another group, but it may not be too big. But of course, it depends on the nature of the spread of the infection, especially where you find that by the time you get to track the people, some of them have already, shared the virus, and so you can't even track that there was someone who was positive there. However, the way we're looking at it is that the numbers of people who are positive is higher in the group that we have targeted than just worrying that because some may be asymptomatic, we might be missing many. We'll miss some, but I think the large number of people would have fallen within those categories that would have tested. The issue, I didn't quite follow what the issue around herd immunity and lockdown, but just to say, the general understanding is that the way to protect the society is by having herd immunity, which develops over a period with the exposure to the virus. But since it's a new virus, there's nowhere in the world where there's adequate herd immunity to be able to break the cycle of infection, because most of the people are, not exposed to the virus, and therefore their bodies have not developed any immunity around it. But when we're dealing with the issue of the lockdown, we're basically creating a physical, physical barrier for the virus to move on by limiting the movement of people until they've shared the virus amongst themselves. So that's really what the issues are. So I don't see that the issues are necessarily contradicting one another. It's a debate that I think we must continue with at that level. But the lockdown had a particular value, and we are all saying that we want to try and move to a slightly different strategy at this point, which is the risk-adjusted approach. Ibrahim raised an interesting question about the numbers climbing up 8 times the world average. And I think, it actually illustrates the issues here, that we may not necessarily agree with some of the postulations and some of the estimations and the hypotheses that have been put in, but we do want to know what's there. And so that's what we tend to give attention to. Our aim is to intervene, whatever the numbers are, in such a way that we can contain the spread of the infection. So whatever the predictions are, we need to try and do our best to reduce the impact, not so much that there's a particular figure that we're aiming at, but just to make sure that we keep a balance, that the rate of the infection should not be so much that our system must fail to cope. That's really what we're trying to do. We have the area of deaths by age right now. We've been actually asking for even more analysis just to understand what is happening in this area. But I think the response here has been quite that we've also noticed, like the rest of the world, the experience that the higher mortalities are associated with the progressing age. So we haven't seen much that is different, except the few cases that we have seen below 40, but I think the pattern is pretty much the same. So the interesting question was, Dr. Cavender, how often does the NCC see these, and how often do we have to change our models and so on? Well, I think we must just say, when we need a bit of kind of forecasting is more when we talk about demand planning, analysis and forecasting what our needs are going to be in terms of beds, ICU beds, non-ICU beds, human resources, PPEs, mortality, and so on. So we may not be able to take everything from one particular model, but we need to be aware of what is in various models. Some of the modelers have actually engaged with them and have asked that, you guys are saying so many different things, why can't you come together? Let's see where you differ so that you can see where we're safe with the numbers and so on. So you rather look at the models, the models more as a buffet as opposed to being an a la carte menu where we'll just go for one and consume it. We actually have a number of things to pick on different ones depending on what we think is helpful to take us forward, as it were. So I do agree with this approach that the models will keep improving as we continue to feed real data. And I think it's also important to start instigating local research onto various areas that will give us more a South African experience in terms of the research findings that will guide us a bit more than that. You see, the models that we've got, I don't think there's a model that was upfront able to predict what happened in the Western Cape. The one model that I saw actually thought that they believed that it was going to be Gauteng exploding first, followed by KwaZulu-Natal. If you follow that, it actually gives you the reason for that, although I can't recall what their reasons were, but it was clear that there are similarities between these two. They were the first two to show the infection, and then also they've got the highest population. The level or the levels of poverty are almost the same. The interconnection between the two is almost a straight line between Gauteng and KZN and so on. So you would actually understand that that is most likely to happen. But lo and behold, what happened? We had an explosion in the Western Cape. Now, I don't see anyone here who has actually come to us and said, we predicted and this is how it's happened. In other words, we're all learning as this thing is happening. So what has happened in the Western Cape, we'll follow up and try and then find out afterwards to say, this might be the reason. So we use them into the future, as it were. So our approach, for example, into the Western Cape is that as much as those numbers are getting completely out of the expected range of increase that we thought would happen, we need to go back and insist on additional interventions. We have actually done so with additional reinforcements of teams to go and work with the Western Cape Provincial Health Department and government so that we can try and contain ultimately these numbers, as it were. There's been a huge amount in the testing that has happened. Now, always the challenge with the media statements is that not all the media statements are all scientific. Some of them could arise from someone who may be a scientist or an expert, but they're not necessarily scientific views. They are political views, they are personal views, and so you can get a criticism of a government by someone, but that doesn't necessarily mean that because that person comes from a particular institution, therefore that makes it a scientific argument. It might just be because it also catches quite a lot of nice, headlines, and therefore it makes a story. So the issue of testing in our case has been a real struggle. We've actually pushed up so much trade testing that in the past few days we've been doing 18,000 tests in 24 hours. It's something that we would have been much higher if we didn't have the well constraints on the diagnostic kits. Now, that issue, in terms of the implementation challenges, someone who criticizes sometimes does not know some of the constraints that are associated with the scale up, the numbers that we've actually ultimately got into. So there's a huge challenge now of having to reorganize, retarget the testing so that you can go and deal with the upsurge in the Western Cape, because that's where you need faster turnaround times and so on. But whilst you've got those kinds of challenges, we cannot be perfect, and we can never, work in like in an ideal situation. It's a real situation that we are dealing with. And so as we go through this whole discussion, it's one of the areas of constraints. Where I agree is that testing gives you a sense as to where you are, but you need to understand who you're testing and what are the factors that are behind the testing. For example, when you've got people who are screened and those who are coming in as patients into the hospital, there are very different kind of categories of people who are testing. When you deal with the staff and you're dealing with people who are exposed in a particular way, your risk levels are not necessarily the same. So the whole issue around testing has got its own dynamics at the back. So I think it's important for us to focus, like what most of the journalists have done now and media now. Let's focus on the cold facts. What is the data all about? Because it also allows us space to be able to listen to areas where we must go and refine and improve. And I think for all of us who have been involved in this exercise, this exchange has been very, very helpful. And in so saying, we have got lots of lessons to learn from many countries. But the fact that you also have many people researching what's going on in different countries, bringing it back here, is also going to help us as we respond. I don't think we'll ever be perfect, but I think with more and more input, it's going to help us to take the whole direction forward. Maybe at a certain point, we'll be able to do a similar, discussion. I'm not sure how quickly it would make a difference, but I certainly would welcome an opportunity to share again with the public and the media as much of this information, because out of the exchange, there's a lot for us to learn. So I want to thank all the presenters, the modelers, and the whole team that's been part of this, and thanks to the media. At this point, I'd like to bring to a close, and thanks, Lwazi and Anban, for facilitating. Thank you very much.
Well, suppose that's the end of that presentation. Initial social distancing and lockdown measures